everyone, and welcome to another Heart for PCOS interview. I am very excited to be sharing with you a very special guest. We have Dr. Helena Teede from Monash University. She has been a champion for the PCOS community for a very long time, and we are honored to have her join us this evening. Hello, Dr. Teede. Thank you so much for joining us for Heart for PCOS.
Thank you so much. It's a pleasure to be with you. And as mentioned earlier, great to chat face to face since we've interacted online so much.
Absolutely. I would love if you could tell everyone a little bit about yourself and your background and involvement with PCOS.
Yeah, so I'm a reproductive endocrinologist, but medically trained, so not someone who trains predominantly or treats women with IVF specifically. And I specialised in women's health early in my career, and actually was working primarily around menopause, which is also a neglected challenge for many women. Natural part of life, but it brings its challenges that are again neglected. But one of the things when I went into practice was I just saw an unprecedented number of young women and adolescents with their mums who invariably with, I have long consultation times, which I choose to do, but with time and empathy, almost every one of them that I consulted with would end up in tears just because they had finally had someone who sat, listened, explained, cared, I suppose, and understood. And it was this group of women affected by this condition, by PCOS, that were most, I think, just neglected and let down by the health system, and much more profoundly affected than you would ever be taught at medical school or ever really realise until you started working with women. And because when I started my practice, there weren't that many female specialists, I pretty soon attracted a fairly large practice because word of mouth is we know that relatives are more likely to have PCOS. So it was really my clinical experience and the fact that it was just causing so much distress and so poorly recognised. So that's how I got into it, Ashley. And then after that, it struck me how many different people were involved in bits of care in this condition and how poorly they communicated and understood the other aspects, and therefore how challenging it was for a woman with a condition to really get a holistic package of care for themselves. And that also was a problem. So I was sort of surrounded by problems, and at the same time I was an academic and I worked mainly in systems change, and I was a mum with 2 young children who'd had infertility myself, and I had to have IVF for both children. And I think there was just, it was just very clear that this condition needed a lot of help and effort. And so rather than just do that one by one, person by person, I decided to take a systems approach, and that involved setting up new dedicated services that were co-designed by women and by adolescents and their families. Then we went on to hold before anyone talked about patient experiences or patient-reported outcomes or patient-centred care, we held a day-long session where we brought all those different specialties and allied health and everyone together and said, what research do we need to do, very naively? And at the end of the day, that day was started and finished by women with a condition. At the end of the day, we decided we didn't need any more research right now. What we needed was guidelines and education for health providers. And that started us on our journey, actually, towards what was the first an Australian guideline and an extensive education program, and then became an international guideline across 71 countries, which is now used across 186 countries. And it's just being updated now as the international guideline. So I think, and all the resources, the app we've talked about that reaches 34,000 women. So if any women would like free evidence-based multilingual advice, a free plug for the ASK PCOS app, which we are very keen to get out there to dispel misinformation, to provide evidence-based information free of charge, and also to get your feedback on how we better reach and support women with a condition. So that's it in a nutshell. Yes, we do a lot of research on the condition, especially understanding the natural history, and work with people all around the world in the condition, including 16 different peer support groups. But it's fair to say our focus has been a great deal over these past years on bringing the evidence together, putting it in every possible unashamed way we can to get it out into the community and for women and for their health providers. And the next guideline, I think, is going to shake that up even more, Ashley.
I hope so, because for far too long, PCOS patients have felt like they were brushed under the rug and that they haven't had voices standing up for them to improve patient care. So I would love you to talk a little bit more about defining and redefining protocols for better PCOS patient care with these international guidelines. What will they eventually mean for patients?
So when you have such a common condition, in an ideal world, Ashley, I'm sure every woman would like to have a well-educated primary care provider. Now, in the US, I know a lot of primary care for women is provided by OBGYNs, but around the rest of the world, it's usually general practitioners. And it does vary. Sometimes it's, community nurses. But the bottom line is the front line for women need much more education about the condition. And there's a really concerted effort and focus on undergraduates, so before they graduate, getting better training, and postgraduate training, which is not just about the medical side, but the psychosocial impacts of the condition. Understanding it is not just about the ovaries, but about the reproductive, but also metabolic and cardiovascular, and quite profound psychological impact that the condition has. So there's a really strong focus on tangible things we're going to do about education in the new guideline. There's a lot more about shared decision-making, lifelong management of this condition. Therefore, it needs to be owned by the woman who has the condition. And really, she is the orchestrator of all of the people that she works with, and is much more informed about the treatment options, including getting over the misinformation. There are some products out there that are inappropriately commercially promoted and do not make much difference at all. And there are some medical treatments that are actually very effective that get inappropriately undermined by those who have other commercial interests. So, the models of care will be a big emphasis, to come back to your question. And that means really much better educated, empathetic, understanding healthcare providers, wherever they no wrong door, wherever you meet them. And then many more tools for shared decision making, so women can be the masters of their journey much more, but then also dedicated clinical services, which can't be there for everyone, but need to be there for those who really need it.
I love that. So diving into this a little more, do you think perception of the syndrome has been the cause of delay in diagnosis for many patients?
We know that's the truth from the evidence, not just my own diagnosis experience with other women, but just the problem with the name. There are no cysts on the ovaries in polycystic ovaries. There are half-developed eggs or follicles that simply develop halfway along and then arrest or stop because of the hormonal condition. It is just a hormonal condition, and it's variable. What we do know now, and we know a lot more, actually, for a long time, doctors like to put things in boxes. This is black, this is white, this is yellow, this is green, and this is the right treatment. PCOS doesn't do that. Neither does type 2 diabetes, neither does higher weight. They are complex conditions with multiple drivers, and it's all about the individual and personalised care. And I think we're now at the point where we can definitely do that. So what we do know is that that women are completely individual in their presentation, in their lifelong journey with PCOS, and what's important to them is different to what's important to the woman sitting next to them. We can have women who are really quite markedly hirsute with excess body hair. It doesn't bother them at all. It's not a problem. And we can have young women who are profoundly distressed by what we almost can't detect as clinicians. So it's really a personal condition. So it is, yes, it's complex and it's diverse, both within a woman, over her life, and between women. But essentially, it has so much more to do with just the ovaries. And by calling it polycystic ovary syndrome, which in languages like in Finland, for example, translates to polyblistered ovary syndrome, you can imagine what that would feel like when you're told you had that. It just completely boxes the condition into one organ in the body and one particular manifestation. And it's just not appropriate. It's really got in the way of women being able to understand and explain to people without stigma what the condition is, what the features are, and how it affects them. Because none of the other. Why does a polycystic ovary syndrome cause significant distress, depression, anxiety, eating disorders? Where does that come from? Well, it doesn't come from arrested follicles on the ovary. So yes, the name is a major impediment. It's a major impediment for services. It's a major impediment for care. It's a major impediment for funding for research. It just gets in the way of everything, Ashley. And it's pretty clear that women with the condition want to change the name too. And I think we're almost there. So that's a different discussion for a different day.
It is, but it's vital because how that impacts me personally as a patient. I had a hysterectomy. I don't have my ovaries anymore. And doctors have told me, well, then you don't have to worry about it. You're cured. You don't have PCOS anymore. Or people who don't have cystic ovaries, you can't have PCOS if you don't have cystic ovaries. So can you talk a little bit about PCOS being endocrine and what that means as far as like cystic ovaries being a symptom and not the actual cause of the condition?
Yeah, definitely. So, so again, just to highlight, they're not actually cysts. So ovarian cysts are a separate condition. They can grow, they can burst, they can cause pain. Pelvic pain is not a feature of PCOS. And one of the important things for women with PCOS to understand is that ovarian cysts, true cysts that need surgical intervention, are a separate condition that needs different treatment. And pelvic pain is not something they should just put down to PCOS. It's really important that they get help for that, because many women also have endometriosis, which is also quite hard to diagnose. And yet they're sort of tapped on the head and said, it's okay, dear, you've got PCOS, which is not a cause of pain. So if we think about the ovaries just being a contributor to, but as a result of that hormone change you mentioned. So we know that 95% of women who have PCOS and are of a higher weight, and the majority of women with PCOS do have a more rapid weight gain, that they will have insulin resistance. The problem with this is that there's no really good simple test for insulin resistance. I can hook people up to all sorts of drips, and we do what we call a clamp study for 6 hours and tell you you're insulin resistant, or I can just know you've got PCOS, so therefore you are insulin resistant. So we don't need a test to tell us that. If you're lean, and many women who are lean with PCOS feel quite neglected because they don't think they're understood, but they are indeed just a variation of PCOS. There are many common features, and they also are very insulin resistant, at least 75 to 80%, as well as the combination with the high androgens, which is a particular type of what we call sex hormone. It's not a male hormone. It's present in women, but women with PCOS just have more, as do men. But it's the combination of those higher hormones and the insulin that cause all problems, including the arrest or the stopping of development of those follicles in the ovary, which then causes more hormone production, and we go around in circles. So it's those two hormones underlying, and then excess weight, higher body weight, makes both of those worse. And so we go round and round in circles. But actually, even things that people don't appreciate this, but for example, conditions like type 1 diabetes, where we give quite high doses of insulin that women have to inject, that causes PCOS, and at quite high rates, because it's causing high insulin levels, which cause high androgen levels. And it was a secondary phenomenon. So because of their insulin treatment, PCOS occurs. So we know what causes it. We know it's a complex combination of genes. It's a combination of what women are exposed to when they're in the womb, because that hormonal environment in the womb makes a difference. And then we also know that there are factors in our lifestyle as we go through life that affect it as well. So there are multiple things that have an impact. And in the end, it's the hormonal environment that our ovaries are sitting around in, but our heart is sitting around in, our brains are sitting around in, the whole of us are sitting around in, that cause the features of the condition.
Continuing on this a little bit, just trying to clear up some misinformation. Many websites, providers, organizations, and even government websites refer to PCOS as a condition of reproductive age women. If we continue to define it in this way, are we overlooking the serious nature of the condition? I mean, not that infertility isn't important, but it is. But shouldn't we also be considering metabolic, or more specifically, because it is Heart Month, the cardiometabolic risks and health in patients with PCOS?
I agree. For example, there is evidence in children at the age of 6 that start to divert, and you can detect people who will go on to have PCOS, they start to change in fact, their weight trajectory from the age of 6. There are definite differences in puberty, in adolescence, and then through to menopause, but also beyond in terms of the cardiac and metabolic features of the condition. And when the new guidelines come out, you'll see what the recommendations will show. In fact, they should be out for consultation at the time we get to PCOS and the heart awareness time. But they much more clearly demonstrate the very significant metabolic impact and psychological impact of this condition, and the levels of distress that are related. So yes, it is absolutely imperative that people understand it is a metabolic condition and that it is a high-risk condition. The other thing, actually, that's also forgotten because of this ovary badge that we have, is the whole issue of pregnancy. So, not only do women in this group have trouble getting pregnant because the eggs are often not released, the good news about that, though, is that treatment is relatively simple. And I just want to say that again, for women with PCOS, the vast majority just need tablet oral therapy to be able to conceive. Few need complex, expensive IVF. And that's really important for everyone to know, because we are seeing more IVF used when it's often not needed. And the other very important message is for most women with PCOS, they can have a family with not much expense or extensive treatment. So really good news. But when pregnancy occurs, the cardiometabolic conditions in pregnancy are really high. So the risk of gestational diabetes, which is high sugars in pregnancy, the risk of high blood pressure in pregnancy, the risk of having a smaller baby, ironically, because the blood supply and the blood vessels in the placenta are not quite as healthy. So there are some really quite important things to know about in pregnancy, all of which we can treat, all of which we can mitigate the effects of, but not if we don't screen for them and not if we don't appreciate it. So there'll be a really big push in the next guidelines around all providers, women and providers, being aware that once pregnancy occurs, which is fantastic, that we need to be really on our guard and really focused on prevention and management and healthy lifestyle, even more so than everyone else in pregnancy. And then as we get to menopause and beyond, we need to continue to be vigilant about both the psychological and the metabolic effects.
Absolutely. One thing that interests me that came out, I guess it was June of this year, there was research done that showed during pregnancy, because of all the cardiometabolic factors kind of being on high alert at that point, that it can cause cardiovascular complications in the mothers and even in the children that are being born. So it is something that we have to be hyper vigilant about and educate people that the journey doesn't end after you get pregnant. It continues, and you have to continue to monitor your care and your health through that period of time. I wanted to circle back a little bit more for the Ask PCOS app. And how can it be used to empower and engage patients in their health to minimize risks for conditions like cardiovascular disease in PCOS?
So the ASK PCOS app, as we said, is freely available. It has it's been designed by women for women with women, really. And it's got about 34,000 users now, multiple languages, and very willing to work with any groups who would like to translate it, the content to other languages. But it's designed around the top 93 questions that women with PCOS have. And it's designed as a tool to answer those questions. So when you go into the platform, you put in, my main concerns are X. So it might be excess hair, it might be pregnancy, or it might be fertility, it might be distress, psychological distress, it might be what your relatives' risks are of PCOS or what your children's risks are, or it might be your cardiovascular risk, your cholesterol, your diabetes risk, long term, or it might be, is my menopause any different because I have this condition? Is my pregnancy any different? So all of those, the questions that women enter, we then filter up the information that's most important to them, and that can change over time. We have a moderator forum so they can put their questions in as they need to. But most importantly, for example, if a woman has a question like, what is cardiovascular disease? Because women don't think it affects them, they think it's a male condition. And yet it's pretty much the number one killer of women. So what we tend to do is they can ask questions like, what is heart disease? What would be the risk factors? What do I need to think about in terms of prevention? And all that information will be provided, but then they get the option to drop out the question, so what is my cholesterol? What is my sugar? What is my personal risk? Once they understand all of that information, and it's written in very health literacy considerate language. And so essentially it allows you to get an understanding and answer your questions in your own time, with your own ability to work through it. And then it gives you the opportunity to drop out those questions to take to your healthcare provider in a written form on your app, so you don't forget, to then be able to run through those questions with the doctor. Should I have my cholesterol checked? The answer is yes. Do I need my blood pressure checked? Yes. Do I need my sugar checked? Yes. How often? And that is personalized. And what do I do about it to prevent it? Because I think that's the really important other thing here, Ashley, is that whilst we are saying polycystic ovary syndrome, again, that ovary label, which is just so inappropriate, has a lot of features, but if women know what they are, if they get empathetic, understanding care, if they're empowered to understand the condition, take charge of it, the app is meant to give them a platform to be able to carry that through life, they will realize that most of the conditions are preventable, or most of the complications are preventable, or if they're not preventable, they're very treatable, like the simple treatment for infertility, which infertility is much easier to treat in PCOS than it is in most other conditions, because it's just that ovulation usually, and maybe other things, but it's usually just the ovulation, and that's relatively easy to help for. But I also think that it's really important that women get evidence-based information that is accurate. There is, for example, the oral contraceptive pill is not for everyone. And we understand there are women who do and don't want to take it, but it's really important that women are informed about the fact that it's actually really effective for a lot of features of PCOS. It works not only for contraception, and women with PCOS do spontaneously get pregnant a number of times. Yeah, and often when they're older, actually, because of the nature of the condition. So they often think they've had their family and they're happily gliding through their 40s, and whoops, all of a sudden that wasn't planned. So it is really important. We still remember contraception is important. It also works on the very nature of the hormones that are the problem for the condition, and probably more effectively than anything else. So it is quite effective for many of the features, but it's got a lot of bad press and a lot of inappropriate, inaccurate misinformation. And also, one version of a pill is not the same as another. Yeah. There are natural estrogens now. There are very low doses. There are more limited side effects. It's not for everyone, and I'm not suggesting that it is, but I'm finding a lot of women feel they cannot take it or don't want to take it because it might be bad for them. Or that a lot of it's because there is misinformation, because there's other people pushing products that are often not as effective, but will cost a lot of money and make others quite wealthy. So just making sure women know why they might or might not choose to take a treatment, any of those treatments, understanding lifestyle in a much more holistic way, understanding the real importance of healthy lifestyle for prevention of excess weight. So it doesn't matter what weight or body size or body shape you are right now. You are what you are. We all are what we are. It's really important women understand that lifestyle alone and diet alone will not long-term lead to very significant weight reduction. 1 in 1,500 women from lifestyle alone will substantially change their weight back into a healthy range if they're already, markedly struggling with their weight. But minor lifestyle changes make a massive difference in terms of prevention. And for women with PCOS, that prevention is critical. It's a bit like saying, I will never take an addictive drug because I would never want to have to deal with addiction and get over it. So I will always try and not put on more weight, because once I've got that weight, it's really, really hard to budge. But that information is not provided. Women often wait until they often are really struggling with higher weight. And that's when people offer help, and that's really hard because it's too hard for them to be able to fix. And the other thing is too, there are some very effective medical and surgical options now that people at least need to be aware of. So healthy lifestyle is good sleep, good mental health, good self-care, the healthiest diet, and the most physical activity that you can do for you at that time in your life.
I love it. I love it. I love it. It's so important because, again, since we're talking about heart disease for Heart Month and Heart for PCOS, 80% of cardiovascular disease is preventable. If we have the right tools, the right resources, the right information, we have a much better chance of avoiding the complications and risks that go along with the condition. So very important. And that's why I encourage everyone to check out the ASK PCOS app. I have checked it out and it really is an amazing tool for anyone who wants to improve their health profile with PCOS. So I have one more final question for you. Do you feel that we're getting closer to a better understanding of PCOS, and how do you feel that could impact minimizing future health risks in patients?
I think we've come a really long way, Ashley. A profound statement that one of the patient group leads said to me probably about 5 years ago. Look, I listened to all of your, the experts sit around and pontificate and talk about all the things they don't understand. And it's really baffling for us, but can you just phrase what you do understand? Can you just tell us what we do know? And then you can all argue about the nuances that we don't know yet. And that was really important. So we do know a lot. And I think that's important for women to know. So we now understand very clearly that this has a genetic predisposition, that it runs in families, that male relatives are also affected. In fact, fathers and brothers are more clearly affected, in fact, than sisters and mothers, or at least than mothers. So we know that there is a complex mix of genetics, and we don't need to be able to pin that down further. It's the same with type 2 diabetes. It's the same with people who are at risk of higher weight. It's a complex mix of genetics, but we know what those genetics are. They are metabolic and they are reproductive, and that's what the mix is. Then we know that that there are changes in the womb, as we mentioned, that may in fact in future be really important treatment targets to prevent complications. We then know pretty much what the natural history is. And as I said, when the guideline comes out, you'll see we're much clearer about some of those features, including metabolic and cardiovascular. So we know what PCOS looks like. We know it is complex. It is different for every woman. And we just need to be comfortable with that. We don't need to put people in boxes, yellow smarties and green smarties and purple smarties. The reality is PCOS is just your condition. And when I'm working with you, it's whatever it looks like for you and whatever's important to you, and whatever your personalized mix will actually give you in terms of what we need to focus on for care. We also know there are effective treatments. There are very effective treatments for the high male hormone levels. There are some effective treatments for the high insulin levels. There are good treatments for hair. For example, the laser therapies are now a lot better for most women, unless it's a really light or blonde coloured hair, but it's often very effective, and there's some good recommendations in the guideline about that. Now we just have to get them subsidised so women can access laser. There is some really effective treatment for infertility. I mean, really has evolved dramatically, and we just need to make sure that women get the least invasive, safest treatment that they need. There is some really good ways to prevent complications in pregnancy and to treat them, really good ways to prevent and treat diabetes and cardiovascular risk. And I think the area that we need to probably do the most work on is bringing all of that together so that healthcare providers are more aware and treat this much more holistically, and that the psychological impact of the condition is understood and mitigated and improved when women have a much better understanding of their condition. So for someone like me who's sitting back saying, we know an awful lot about this condition, we know it, we've got really good treatments and prevention plans across the lifespan, and we need to just make sure women understand that and can create their own pathway with their providers together. And different providers may jump on the train at different times, but the train belongs to the woman who has the condition. So if we do that and we do it better, I think it is a very different condition than if someone just fails to get diagnosed, fails to appreciate the other features outside one particular factors, for example, just getting their infertility treated, fails to have empathetic care that understands the broader aspects, fails to be empowered to make a difference in their own life, because a lot of this is about being as healthy as you can be, and that's really up to you with our support. It's not up to us. But I think my message is we've got a lot to be positive about. And yes, there is a lot more work to do, but we can do a lot if we work together.
I agree with you. I love that key word, working together. It really needs to be a marriage between the providers and the patients. And if we're really going to effectuate change and get funding for research and raise more awareness, then we all have to be part of a team. So I thank you so much for always including my patient voice and the patient voices of others to create this awareness and this change. If people wanted to learn more about what you do or where to find you or the app, where can they do so?
So if you just search up Monash, MONASH, PCOS, there is a whole range of resources in multiple languages, written, audio, visual, all free, all government funded, no commercial backing, all designed with women. And so that would be a good source. Ask PCOS on any app store or platform. You can find the Ask app. There's also others on Ask Early Menopause. There'll be one on Ask Heart Health soon, and there'll be Ask Healthy Pregnancy. But at the moment, the main one that's involved, used around the world, 186 countries, I think, is the Ask PCOS. So App Store or Monash PCOS, Ashley.
That's wonderful. Thank you so much for sharing your expertise and your time with us today. Everyone, keep continuing to tune in to Heart for PCOS throughout February. We have over 60 researchers, providers, patients that are all coming together, raising awareness and providing education about PCOS and keeping you healthy, keeping those hearts beating strong. So thank you for joining us. Have a wonderful afternoon.